Awesome. What an incredible way to start off today. Thank you so much, Dr. Wong. A couple of you have already asked in the chat, and just a quick reminder, in order to download presenter slides, you can scroll down a little bit below your feed down there. You'll see a number of tabs. One of them says slides, materials, and handouts. You can go over to that tab, and all of our presenter slides are there available for download. In order to download, you're going to go over to the icon, look for the PDF icon in the top right-hand corner, and you should be able to download it that way. So next up is our lightning round. For those of you who aren't familiar, lightning round presentations are a bit different than your traditional conference talk. Each presenter is going to have only 8 minutes to describe their research before we move on to the next presentation. And we're going to save some time at the end of this segment to take some questions. So first up, we've got Dr. Frances Anyan. Dr. Anyan is a newly funded Career Development Awardee. Very excited for her. Congratulations. At the Vision 1 MyRec with the U.S. Department of Veterans Affairs. Her areas of expertise include dialectical behavior therapy and suicide risk in military veterans. Dr. Anyan, take it away.
Wonderful. Thank you so much for having me and for the kind introduction. I am excited to present to you, some work that myself and some colleagues at the West Haven VA have been doing to try to meet the needs of veterans who have been referred for the DBT skills group. And so I am going to continue on here. And just to throw it out there, the views that are presented in this do not reflect our own and don't reflect the views of the federal government. And we've been supported by a couple different entities within the VA. And we've got and I receive salary support from the VA, and Dr. Decker is a trainer in mentorship with behavioral tech as well. So a little bit of background, as you may know, DBT and DBT Skills Group is an evidence-based treatment for clients with borderline personality disorder who struggle with emotion dysregulation. At the West Haven VA, we've had a DBT Skills Group only program that has been running for the last 11 years, headed up by Dr. Suzanne Decker. Over the course of our time working with veterans referred for DBT Skills Group, we've noticed a couple of challenges. There are two groups of patient populations that haven't really been as engaged in DBT Skills Group as we had hoped. We've noticed that there are some veterans who've expressed some ambivalence about committing to DBT Skills Group and don't actually accept a referral. And we've also noticed that folks who've been referred but need to wait on the wait list on DBT Skills Group before a slot arrives will sometimes drop out when we invite them to eventually join. In order to meet these needs, we tried to develop we did develop and then piloted a very brief, time-limited motivational enhancement intervention that we call the Drop-In DBT Skills Group, with the aim of facilitating referrals on to the main DBT Skills Group. We also collected some data as we did this, and so that we can report on the group's feasibility, acceptability, and preliminary referral efficacy. So what did this actually look like? So we were working with veterans who belong from those two groups. So we're working with veterans who meet criteria for the standard DBT skills group and express ambivalence about joining the standard DBT skills group. The way we worked with referring providers is that we said, try to refer to the main DBT skills group. And if folks decline that, then you can offer the drop-in DBT skills group. We also, and I just want to confirm, I see there's some chatter about not being able to hear me. Is my audio coming through okay? Okay, Great, thank you. And then we're also working with veterans who are on the wait list for the standard DBT skills group. So what did this group actually look like? If you look to the right-hand side of the bottom table, you can see some description or a description about what that drop-in DBT skills group was like in comparison to what we call the standard or adherent DBT skills group. So this group met for 1 hour for 4 weeks. In 4-week cycles, which is different than the 2-hour per week for 24 weeks in the standard DBT skills group. Instead of covering one new skill each week for 24 weeks, we covered 4 introductory skills, sampling from the 4 different modules in DBT skills. Whereas attendance is really expected for a standard DBT skills group, this was a drop-in group. So we encouraged attendance, but we did not require attendance. There was no 3-miss or attendance contingency. We know that homework assignment and review is so crucial in the standard DBT skills group. For the purposes of the drop-in DBT skills group, however, we did not assign homework, and nor did we have homework to then review. And the purpose of this was the focus was really reinforcing the attendance, reinforcing the engagement of folks who attended the drop-in DBT skills group, as opposed to the reinforcement of learning and application of effective skills use, as it would be in the standard DBT skills group. So what were we evaluating, and what did we find? As I mentioned before, we were collecting some process-oriented data around this pilot. So we were curious about, are we going to get referrals? Is anyone going to come? These are people who, by and large, or many of whom actually turned down an invitation to join. So is anyone going to be interested in trying this out? If they try it out once, are they going to come back? And then ultimately, how effective is this group in facilitating referrals to the true evidence-based treatment of the standard DBT skills group? So if you look on the right-hand side, the farmost column, you'll see our results. So in the 8 months that we were doing this, we had 44 veterans who were referred. And the vast majority of them, 81% of those veterans, actually attended. They accepted an invitation to join. By and large, this comprised of veterans who had initially declined an invitation. So of those 37, 31 were veterans who had expressed ambivalence and had initially declined an invitation to the standard DBT skills group. Only 6 were veterans who were on the wait list. So of those veterans who attended one session, most of them, 87% of them, came back for at least another session. So 32 of those initial 37 returned. And then ultimately, this big question, how did we do in facilitating referrals to the main DBT skills group? Almost half of those veterans, including 14 or so, and so 14 of those 17 were veterans who had initially declined an invitation to DBT skills group, who then requested a referral at the end of this. So we were pretty impressed by this. We were working primarily with a group of patients who really seemed like a good fit and had expressed ambivalence about joining. And our outcomes, our preliminary outcomes of feasibility, acceptability, and referral efficacy seemed actually pretty strong, especially compared to other motivational enhancement interventions that we had looked into too. We were trying to figure out why this was. And one of the things that we thought about is how this drop-in skills group may have functioned as a low-demand exposure for veterans who had some concerns about what it was going to be like trying out a group context, or they had some questions about what DBT skills might be all about. There are some limitations. So our outcomes for this were all process oriented. We didn't actually collect any data on how this impacted veteran client outcomes. So how this impacted their dysregulation. We don't have that. So I'm curious to kind of continue collecting that data as we go. And ultimately, I'm really curious about how a program like this could help facilitate referrals to this evidence-based treatment that we know is so effective for folks struggling with dysregulation. So thank you. I appreciate you listening.
Awesome. Fantastic job, Dr. Anyan. Next up, Drs. Erica Carr, Jane Carter, and Mark Hilbrand. Dr. Carr is a professor at the Yale School of Medicine and director of inpatient psychology at Connecticut Mental Health Center. Her work focuses on behavioral support interventions and the need of women with serious mental illness. Dr. Carr?
So today we're talking about using positive behavioral technology in inpatient settings for those with BPD. And the model we use for this is called Trauma-Informed Behavioral Supports, and we call it TIBS for short. It's a nice little acronym to refer to it. And I'm presenting today, I'm Erica Carr, and I'm presenting with my colleagues, Dr. Carter and Dr. Hilbrand. And purposely, they're presenting with me today because it's an all hands on deck effort, and it really is an interdisciplinary collaborative effort. So it's really important that we got to do this together today. So I wanted to start with what do we know and what we don't. We do know that people that are diagnosed with BPD may be hospitalized a lot because of trauma-related symptoms, such as aggression against self or others. However, it's not always the most effective thing. In fact, we know that Linehan tries, or she says, try to not hospitalize as much as you can. So today we're talking about using positive behavioral technology in inpatient settings for those with BPD. And the model we use for this is called Trauma-Informed Behavioral Supports, and we call it TIBS for short. It's a nice little acronym to refer to it. And I'm presenting today, I'm Erica Carr, and I'm presenting with my colleagues, Dr. Carter and Dr. Hilbrand. And purposely, they're presenting with me today because it's an all hands on deck effort, and it really is an interdisciplinary collaborative effort. So it's really important that we got to do this together today. So I wanted to start with what do we know and what we don't. We do know that people that are diagnosed with BPD may be hospitalized a lot. So today we're talking about using positive behavioral technology in inpatient settings for those with BPD. And the model we use for this is called Trauma-Informed. So today we're talking about using positive behavioral technology in inpatient settings for those with BPD. And the model we use for this is called Trauma-Informed Behavioral Supports, and we call it TIBS for short. It's a nice little acronym to refer to it. And I'm presenting today, I'm Erica Carr, and I'm presenting with my colleagues, Dr. Carter and Dr. Hilbrand. And purposely, they're presenting with me today because it's an all hands on deck effort, and it really is an interdisciplinary collaborative effort. So it's really important that we got to do this together today. So I wanted to start with what do we know and what we don't. We do know that people that are diagnosed with BPD may be hospitalized a lot because of trauma-related symptoms, such as aggression against self or others. However, it's not always the most effective thing. In fact, we know that Linehan tries, or she says, try to not hospitalize as much as you can. And the reason for that is these environments themselves may be really reinforcing for that very behavior that we're trying to help people not act on. You know, we're trying to really help them get better at dealing with the emotions, the action urges that are coming, and not make that an action taken that they're actually engaging in. We're hoping that they can have more skillful behavior. But inpatient settings are just ripe for sometimes, presenting coercive environments, getting in this tug of war with someone, because we don't want them to have that. It's a risk. It stresses everyone out. It stresses staff out. It can stress the whole milieu out. And that in itself can also cause a dynamic or an environment which causes the very behavior we're trying to help them avoid and have more effective behavior. So it's really important for us to pay attention to this. And we don't have a lot of research on this. And it's in fact interesting that Linehan talks about the lack of research we have for what inpatients do and their effectiveness. So trauma-informed behavioral supports, or TIBS, this is a new model using positive behavioral supports. And this is a way of using non-coercive, non-punitive ways of working with people. We try to do this from integrating a trauma-informed care perspective. What has happened to this person versus what is wrong with this person? We use DBT because of its strong efficacy and the interventions we see that really work psychodynamic theory, which helps us understand the person and maybe how they developed and how dynamics occur between that person and others. And then, of course, behavioral technology, which helps us understanding why the behavior occurs and how we can do things different. It's very interdisciplinary. We try to use a functional analysis of understanding the behavior and how we can do things differently and teach them to be more skillful, but also really teach us to be more skillful. So it's really strong educational component. And it really involves a lot of system and community-wide collaboration. So everybody's working together and on deck.
So as Erica was mentioning, this is a new model that really takes the kind of trauma-informed approach to understand symptoms as a result of trauma, diagnoses of PTSD, and it makes a plan for how and when to treat and if to treat based on what the person is specifically presenting with, so the behavioral component of their presentation. So we have it bolded here that it is really kind of focused on developing new skills for the patient and the entire environment. So that's kind of what the functional analysis of behavior is talking about. It really looks at the whole system. It operates with a personalized plan while using the overall TIBS approach. And in terms of observational statuses, it's very conservative in terms of how frequently it uses those. And it has this strong component of validation for the individual based on their needs and what they have kind of expressed as being desires. So one of the results of this is that it increases the understanding in terms of our understanding as treaters and also other people in the team. They are now trained to react to specific behaviors. And another focus that is really important and kind of central to the TIBS model is that it is focused on building a meaningful life for individuals with this DRO, which is kind of just like developing reinforced other behaviors. So we want positive behaviors from the individual, and those behaviors are things that are goals for that person. So in the current study, we had 15 individuals on an inpatient unit. All of the individuals have a diagnosis of borderline personality disorder and challenging behaviors. And you see some of the demographic details there in terms of women. It was majority women and minority men, and the age between 19 and 65. There was comorbidity in the group, so dual diagnosis very common in this sample. All of the individuals in the study had a lower SES, 67% white, 27% African American, and one person who declined their ethnic origin. So in terms of level of functioning and the behaviors that were endorsed, we compared people in a 3-month pre-treatment and 6-month post-treatment time period. And the overt aggression scale was used to measure aggression in this group.
What we found was that this approach was very effective at reducing verbal aggression. Verbal aggression scores diminished by 3/4. Aggression against objects, against self in the form of self-injury and against others also decreased between 10 and 40%. So this is a pilot study. It certainly suggests that this is an effective approach to diminish aggressive behavior in individuals with borderline personality disorder. So this is an innovation. We're just at the beginning of investigating this. TIBS is really a promising approach. We need to have more detailed studies of this to explore this further.
Thank you.
Awesome. Thanks so much, team. Next, we've got Gabrielle Ilagan. Gabrielle is a doctoral student at Fordham University in New York City, and she's focusing her work on personality disorders, self-injury, and access to care. Gabrielle?
Hi, everyone. Hope you can all see and hear me. But so when we think about a friend or a client being suicidal, most people tend to think of it as a unitary state of mind. But it's possible to take a more granular view because if you zoom in, there are various aspects of suicidal thinking. And not only are there different dimensions of suicidal thinking, but sometimes there's even an internal struggle between them, like the wish to live and the wish to die. So traditionally, researchers have assumed that these are on opposite ends of a spectrum, and you either strongly want to die and don't want to live, or you strongly want to live and you don't want to die, or maybe you're somewhere in the middle. But different facets of suicidal thinking might actually be less coherent and more distinct than we originally assumed. So, for example, the wish to die and the wish to live aren't always inversely related, and you can, for example, be high on both or low on both. And so, most research on suicide to date, including on this topic, has tested between person research questions. So, for example, if this graph down here was a graph of 3 people's scores and each color was a person, and each small dot was a score from that person at different times throughout the study, between person questions compare each person's average score on the outcome. So it compares like each person's like a little bit bigger dot and compares it between people. So, for example, the blue person tends to have a higher level of suicide on average than the yellow and green people. And researchers call this individual differences. But you can also see that if you choose any single person, that the individual will have variation within scores. So there's like a whole spread of these dots are like of the same color. They're not all of the scores are at the average level. So in other words, they have within person variation. So by using a method called experience sampling, where participants report every day, often multiple times a day, on what they're thinking or feeling in the moment, researchers can get an idea of how things like suicidal thoughts fluctuate from moment to moment within each person. So in this study specifically, we aim to examine the within-person coherence and stability of items measuring different facets of suicidal thinking. So for example, in the moment, if someone has a stronger wish to die relative to their own average, does that also tend to be accompanied by, say, a weaker wish to live relative to, again, their own average in the same moment? So to study this, we recruited 60 adults from the community in the Bronx in New York who either attempted suicide or self-harmed in the past month. A little over half were women and 85% were Black, Indigenous, or people of color. There was a baseline session where they answered questionnaires and they were oriented to the experience sampling part of the study. And then those daily surveys were texted to the participants' smartphones 4 times a day for 10 days. And these short surveys had 3 items that measured suicidal thinking. I wanted to live, life was not worth living, I thought about killing myself. So these were our results. All 3 suicidal thinking facets only had moderate within-person correlations. And within-person correlations have a little bit of a different meaning than the correlation among individual differences that most of us might be used to, but they still range from -1 to 1. So let's take this negative 0.29 correlation between wanting to live and thinking about killing oneself. This number describes the extent to which elevations in wanting to live relative to someone's usual level of wanting to live, like to what extent does that correspond to decreases in thinking about killing oneself relative to your usual thoughts of killing oneself at the same like time point. So the strongest correlation was between thoughts of life not worth living and of thoughts of not killing oneself, positively correlated at 0.45. And the wish to live was negatively correlated with thoughts of killing oneself and of life not worth living. So this means that in moments when someone had more intense than their own usual thoughts of killing oneself or life not worth living, they tended to want to live less than they did on average. But again, these correlations weren't very strong, suggesting that suicidal thinking isn't just one unitary construct. And the between-person correlations were in the same direction, just larger, meaning that different facets seem more coherent when you're comparing between people and not within people. And we also looked at lagged within person correlations to see how consistent the ratings for each item were from one time point to the next time point. So that would have been around 3 or 4 hours later. Does it tend to stay stable? And these correlations revealed that thoughts of killing oneself showed the highest stability over time, followed by thoughts of not worth living, and then the wish to live was the least stable out of the three. And then finally, it's not on the slide, but we also looked at intra-class correlation coefficients, which is just a technical term that tells us what proportion of the total variance or spread of those small dots in the outcome is chalked up to differences between rather than within people. And each facet actually had a different intra-class correlation. So thoughts of killing oneself had the highest proportion of variance, 54%, that was explained by differences between rather than within people, followed by the wish to live, and then thoughts of life worth living. So this is evidence that there's different facets of suicidal thoughts that fluctuate within individuals throughout the day that deserve kind of more nuanced attention. It's not just one thing. And we can think about suicidal thinking as multidimensional and dynamic, meaning it will change throughout the day. And these different facets might have different correlates. So considering these different dimensions as separate things might provide context for understanding how people can transition from thinking about suicide to acting on those thoughts. And it might also suggest that we can track and target each of these different dimensions in treatment to try to address suicidal thinking from multiple sides. So big thanks to all the participants of this study, and thank you all for having me here today.
Fantastic job. Only two more now. So next is Dr. Nadine Leriviere. Those of you who joined us last year may remember her incredible work on the occupational challenges of individuals living with borderline personality disorder. Dr. Leriviere, you're up.
Hello, everyone. Thank you for having me again this year. It's a wonderful event. Thank you for the nice introduction as well. So this year, I will highlight some of the projects we are currently working on that aim, once again, to look at daily life challenges. But this time around, it is really with a focus to give a voice to men living with BPD. So I'd like to acknowledge the work of my colleagues with me on these projects. Marc Corbière is a specialist on work rehabilitation and mental health. And the two doctors are psychiatrists, Dr. Pierre David and Dr. Lionel Cayol, who are specialized in personality disorders and have really a strong interest and preoccupation of understanding better the needs of men with BPD. Really, it's quite recent that studies have started to focus a little bit more specifically on men with BPD. There are different hypotheses around that, but what we see objectively is that in studies where a lot of the times it's clinical samples that are constituted, the proportion of women in studies reflect the proportion of women who seek mental health services, women with BPD. So you see the proportions on the slide. It's around more or less 70% of women with BPD who are seen in mental health services, whereas we see 30% of men. And when we look at epidemiological data, so populational surveys, there was one recently conducted in the province of Quebec, where I come from, and we see overall that it's not that far away, the prevalence of BPD in men and women. So overall, what we can say and what we can see is that men are growingly being diagnosed with BPD. The studies that compared men and women in terms of their clinical symptoms and clinical characteristics have mixed findings, but there is a common profile we can start to describe in men with BPD. Overall, men with BPD tend to have more externalized symptoms, whereas women with BPD tend to have more internalized symptoms. So what will that mean? It will mean that in general, men will tend to put themselves more at risk. And so behaviors might be more explosive, aggressive towards themselves or towards others. One thing that we see as well is that romantic relationships is an aspect of life that is quite overwhelming and invasive. And finally, maybe because of clinical presentation or maybe because of uh, gender bias and diagnosis, it's something that has been documented in the literature. Often men with BPD will have narcissistic traits or antisocial traits associated to BPD. I am particularly interested in daily life functioning, and we've just finished a scoping review on this question. So we examined the literature and we also consulted about 10 clinicians from different disciplines, but helping people with BPD. So what we see overall with men that live with BPD in their daily life is that several domains of life have not been explored at all, such as the role of fatherhood, such as leisure activities. So we need to continue to explore for sure. What we know is that the common thread is that in men with BPD, there is a tendency to use avoidance and withdrawal behaviors when facing struggles in daily life. For example, in the work domain, what seems to come out as a profile is that there's frequent job changes because mainly job tends not to be meaningful for men, that they work because they need to work and not necessarily because they enjoy their job. And so that leads to under engagement, for example, or sabotage. Another aspect of life that has been documented is a tendency for men to over engage in physical activity for different avoidance types of reasons. And finally, because of these externalized symptoms, they translate in daily life, such as reckless driving, or what has been seen is things like intoxications with substances in public places. We are currently doing a survey where we want to dig deeper into the daily life of people with BPD. We want as many men as women. We are working on that. Currently, I can just present preliminary trends. We have 9 men and 39 women, and we include people with BPD who have a job because we want to look at how do they maintain their job, as we know that's one of the biggest challenge for people with BPD. So what we see in this slide is that our men with BPD, or our 9 men compared to our 9 women and 39 women, if you look at the congruence of their job with their identity, it's similar to what I said before with the scoping review, is that they're not as in a job that is linked to their interest or their sense of competency or even related to their training. What strategies do they put into place more frequently to keep their employment? They mention most frequently that they adopt mindfulness types of strategies to stay in the here and now, that they plan very carefully their days at work, that sleep is something that they really take seriously to have good sleeping habits, and that at work they keep a distance with their colleagues and not become too personal. The most challenging areas of life where they seem to have more difficulties of accomplishing these activities in a more satisfactory way are around healthy habits, eating habits, physical exercise, managing their energy, and finally participating in community activities. So for us, where do we go from here? It gives us, for sure, the knowledge we will gain out of the strategies that men and women share with us to maintain their employment will enrich our current intervention that we are developing around work participation and BPD. And we will highlight the similarities and differences between men and women so that all can identify. We also are thinking of maybe providing more explicitly lifestyle interventions, as it seems to be something that would fulfill a need for men. And finally, look at, is there generational differences between men with regards to their social participation and help-seeking behaviors?
Awesome. Thank you so much, Nadine. And last but certainly not least, we have Dr. Sarah Barnes. Dr. Barnes is an incredible psychologist with the Yale New Haven Hospital, with an expertise in adolescent mental health and use of measurement-based care to improve treatment outcomes in dialectical behavior therapy. Dr. Barnes?
All right, thank you so much. I'm very excited to be talking with y'all a little bit today about ways that our intensive outpatient DBT program at Yale New Haven Hospital is incorporating measurement-based care into our work. I should say that we are in the early adoption stages in our program of pulling in elements of MBC into our work. So I'll be talking with y'all a little bit today about some things that we've learned along the ways and maybe get y'all thinking about how you all can also pull in measurement-based care into your own practice. Before we go into that though, let's take a pause and talk a little bit about what measurement-based care is. So measurement-based care, or MBC, refers to routine collection of patient-reported progress data throughout their treatment in order to guide clinical decision-making and improve care. Now, as well, we all know, DBT is no stranger to incorporating measurement in our treatment. You know, like we could think of the daily diary card that we ask our patients to complete as one example of this. However, MBC differs in some ways in that it follows this three-step process of collect, share, and act. And so what we mean by that is measurement-based care involves the routine collection of patient-reported outcomes using standardized measurements. So these are questionnaires or assessment tools that have strong psychometric properties that are routinely administered at regular intervals throughout treatment. So we routinely collect these data, and then there's this process of sharing timely feedback with our patients about their progress scores and trends that we're seeing in their data. And then finally, we take those discussions and we take actions on the data in collaboration with our patients in order to guide their treatment. And through this process of collect, share, and act, MBC has an enormous potential to act as another intervention that we can use with our patients and can help patients and providers alike better understand the nature and course of patients' challenges and areas of strength, which we can then pull into our larger DBT treatment framework. Now that said, when we are implementing a new sort of anything, there are lots and lots of barriers and challenges. And I like to think about barriers with MBC falling into maybe systems or larger system-specific barriers. And then also we can think about barriers within our particular population. And that's what I'll spend some time talking about here. So individuals with lived experiences of BPD are often presenting with a number of emotional and behavioral complexities that might make selecting a measure quite difficult. There are often lots and lots of different concepts or topics that we would want to assess and get a better understanding of from our patients. And when we're thinking about adopting measurement-based care, we want to be thoughtful in selecting 1 or 2 measures that are brief that we can administer and incorporate into our treatment. And that can be difficult when there are multiple moving targets that we might want to get a handle on. In a similar way, we might find that there are some difficulties in balancing this regular administration and feedback of measures while operating in our DBT treatment hierarchy. So for example, we may have plans to share feedback on measures that our patients have completed in a session, and in reviewing their diary card, we see that maybe there are life-threatening behaviors that our DBT treatment model would say, this is where we intervene first. And so there can be a little bit of a balancing act in how do we prioritize both following our DBT treatment hierarchy and incorporating these measures and discussing the findings in our sessions. Now, one of the really cool things about the Yale-New Haven Hospital DBT IOP program is that we have a number of training clinicians who really help support and run our program. And so for our specific setting, when we're thinking about how do we incorporate NBC in an effective way, one of the things that we've been very mindful of is supporting our training clinicians and helping us do this. And so first and foremost, what that would look like is making sure that our training clinicians have a solid foundation and understanding of what our measures are. So what are the measures that we're including? What are the specific items or questions that are showing up there? How might those measures and the items relate to specific DBT skills or specific things that we can pull into our DBT treatment? And then a step beyond that, beyond having this foundation of what the measures we're incorporating are, we know that rationale is such a key and critical element of engagement in the MBC process. So when we're working with our trainees, we want to ensure that they solidly understand the rationale of measurement-based care themselves, and that they're able to explain this to patients in very plain language, the importance and the value and the repeated process of measurement-based care. We know that DBT has tons and tons of moving parts and that we ask a lot of our patients. And so we want our trainees to be able to help our patients understand that this is not simply another thing that we're asking them to do, but rather it really connects to their life worth living goals, and it can help us understand other strategies that we can pull in to help our patients reach their life worth living goals. And I think that idea really lends itself to a nice discussion about the benefits of measurement-based care, particularly when we think about adopting MBC and a DBT framework. So MBC can really serve as a grounding force that can help us press pause and remind us to share this regular and individualized feedback with our patients throughout the course of their treatment. And within those discussions, within this process of reviewing and talking about the data that are generated from our patients, it really allows us as treatment providers and our patients the opportunity to get curious about what's happening outside of treatment that might be having bearing on the treatment itself. And again, within those discussions, we can also think about course correcting if need be. So there may be opportunities to add in or take out specific skills or strategies based on what we're seeing generated in these data from our patients. I often think about the daily diary card as a really zoomed in perspective on specific behaviors that we're asking our patients to track and that we're targeting with our patients. And I think one of the cool things about MBC as a process is that it can help us zoom out a bit to put those specific behaviors into context. And relatedly, MBC also can help us zoom in, and we can look at specific questions or items on the measurements that we're using to think about certain skills that may be especially well suited for a particular moment. And finally, and maybe perhaps one of the coolest things about measurement-based care within a DBT framework is that measurement-based care really empowers individuals to be active participants in their treatment. Because by definition, MBC is inviting patients to reflect and comment on the trends that they're seeing in their data and to voice their thoughts about what those trends might suggest. So MBC as a process can really serve as a tool that helps shape active treatment collaboration and engagement. And as DBT providers, we know and we believe that DBT is a treatment between equals. And so this is another tool that we can use to really live that assumption of the work that we do. So thank you so much for letting me talk a little bit about one of my favorite things, which is measurement-based care. I have really appreciated this opportunity, and I'm looking forward to the rest of the conference.
Awesome. Thank you all so much. What an incredible line of presentations. Consolidating a presentation into such a brief period of time is never easy. And you've all done so with seemingly grace and ease. So well done. I'd now like to welcome all of our lightning round presenters back in for a couple of audience questions. And again, if you have any questions for our presenters, feel free to put them in the chat. They are being fed into us. Okay, so first question for Francis. What were the intro skills that were taught in that drop-in DBT group?
Sure. So when we were thinking about selecting the skills that we covered, one of the things that we were weighing was one of the things that we were considering was wanting to select skills that didn't require baseline knowledge or a baseline understanding of other DBT skills, knowing that they often build on each other. And so the skills that we selected were two from the distress tolerance module. So we taught stop and we taught self-soothe. From the interpersonal effectiveness module, we taught about clarifying goals in interpersonal situations. So looking at how identifying whether your priority is the objective, whether your priority is the relationship, or whether your priority is self-respect can help you approach situations with other people. And then we also taught about the function of emotions. So looking at what could emotions be communicating from you, or communicating to you rather. So that first session of the emotion regulation module, but not going so far into model of emotions.
Yeah, no, that makes a lot of sense. So literally, like you said, like real introductory skills. You're not getting super into any kind of particular module, but you're kind of getting a flavor of what all of the skills kind of look like.
Exactly. The name of the game for this was foot in the door in many.
Yes.
In many
That makes a lot of sense. Awesome. Thank you. For Erica's team, somebody asked, when we have someone with BPD who's court ordered to attend inpatient substance use treatment, what do you recommend as like best and most effective way to provide treatment?
That's a great question. I think one of the most important thing is building connection and rapport with the person and starting from there. Obviously, they don't want to be there. They've been put there against their will, maybe. And I can think of a specific case where we've had that, and even where some of these externalizing behaviors can occur because of that very situation. But building, I think, their own enhancement and motivation for being there, and how does that connect to building a life of meaning? They may not agree with the fact that they need treatment or that they have a substance use problem, but they may connect with, I don't want to go through some of those traumatic experiences again, or I want to get back to having a job I like, or being an artist, or this or that. And so starting from there and what's important in their life, building rapport, offering them choices, and absolutely validating that that must be terrible to be put in a situation where you are ordered to do something, So to absolutely validate away. And I don't know what else Mark would say, but.
Avoid coercion. I would say avoid coercion at all costs.
Mm-hmm. Yeah, and this sounds really reminiscent of Nadine's talks on like finding things that the person is really motivated in and things you can kind of align with them on, so that it's okay. If you have to be here, you might as well, let's find a way for it to be helpful for you.
Absolutely.
Awesome. Thank you so much. Fantastic. Nadine, we had a question. Is there a difference between men with borderline personality disorder and narcissistic traits versus men with narcissistic personality disorder and borderline traits? So we kind of get a little muddy.
That would be the answer. I think it's especially when we talk about traits and other disorders. So it's a mix, and they often mix together. And I think that the psychiatrist colleagues with whom I work would say that in men, it's probably more challenging to diagnose BPD because antisocial personality disorder or traits, or narcissistic personality disorder and traits. Again, these are kind of diagnoses when they are related to behaviors that can tend to be associated more with men, whereas the BPD features tend to be more associated with men. So there's muddiness and there's possible gender bias in diagnosing because the same behavior, because it's seen in a man, can be more associated to narcissism or antisocial behavior. But the total package of all of the difficulties the person is facing might be more BPD. So in the end.
Yeah,
so it's
that's
a challenge to distinguish all of those. It is a challenge.
Yeah,
Yes.
that's a really, really good point. I think a lot of times we forget that like our diagnostic classification system is really only about 100 years old, and it's left to a lot of interpretation for the person making the diagnosis, which also means that there's a lot of room for bias, especially gender bias, when we're thinking about these things. Awesome. Question for you, Gabrielle. So your work using ecological momentary assessment kind of shows that suicidal ideation can sort of bounce around all the time, right? And so how do you know you're kind of catching a person at the right time? If one moment they might be wanting to kill themselves, the next moment they're like, no, I'm fine. How do you know, either as a family member or a clinician, how do you know you're catching somebody at the right time?
That is a great question that I don't think we actually have an answer to yet. I think this is just such a new method of research that the evidence is still building. So hopefully, I mean, I don't think we'll have an answer next year either, but I think like all of these different studies that use these methods where you're looking at it more from a moment-to-moment basis, the ideal is that eventually we can pool this knowledge to figure out like what really does predict the shift from one moment to the next, from thinking about it to acting on it. And how can we even tailor interventions, for example, to be pinged to your smartphone when you do report this like sudden change? But I don't think we're quite there yet.
Yeah, that almost reminds me of like DBT phone coaching, right? The idea is, all right, when you're in session with us, you may not be having these thoughts or having these feelings, but maybe 2 hours after you leave session, bam, they come up, and how are you going to deal with them? And DBT phone coaching, I think one of the big benefits is that idea of like having a therapist in your pocket. And it sounds like this work coming from the EMA kind of work that you're doing is really kind of highlighting the importance of that.
Yeah, for sure.
Awesome. For Sarah, somebody asked, what are the measures you found most useful with this population? And I know, Sarah, this is a little bit of a loaded question.
Emily's laughing because Emily and I have had multiple conversations about this. So I would answer by saying that in our program, we've got two different systems of measurement. So we have a larger measurement system where we're collecting a longer battery of assessments at regular points throughout our IOP. So like at week 1, week 5, and week 8, which would correspond to beginning, middle, and end of treatment. Some of these measures include the DSL supplement, the Beck Hopelessness Scale. There's a measure of quality of life. So that's our larger system of measurement. But then we have our MBC, our serial measurement. And so this is the weekly administration of measures. And we've gone through several different iterations of what measure we want to look at, in part because one of the requirements of MBC is that our measures have strong psychometrics and that they are sensitive enough to pick up changes at the intervals at which we're measuring. So in our IOP setting, we're measuring weekly. And so we need measures that can detect measurable change across that interval. One of the things that's happening in the larger Yale-New Haven hospital system is that there's lots of MBC that's happening in other IOPs and other settings. And some of the measures that have been used there are the PROMIS, anxiety, and depression scales. Some programs are using the PHQ-9 and the GAD-7 as well, but a lot of our adult population are using those PROMIS, anxiety, and depression scales. Because we get quite a few people in the DBT specific IOP transferred from other IOPs or coming from other places within the hospital, and they already have PROMIS data, we decided to use the PROMIS anxiety and depression scales as our serial measurement. We also consulted with our program psychiatrist who sees every one of our patients. And one of the things that she had shared was that these are often experiences of anxiety and depression are often things that are coming up in those med management meetings. And so because those measures are strong MBC measures, because they're things that are being discussed in meetings with other providers, because they're measures where patients might have existing data because they're coming from other places within the health system, we chose those two measures. But then we have our larger measurement battery that looks at some DBT, BPD, more specific information that we're collecting at more intervals that are less frequent throughout treatment.
That makes a lot of sense. The big considerations are not necessarily not just like who is the patient sitting in front of me, but also what is the system in which I'm working, and how can I kind of coordinate efforts so that it works most efficiently. Awesome. We've only got a couple more minutes, time for a couple more questions. This idea of, and this is something I'll open up to the entire panel. Somebody said, excellent explanation for differential diagnosis through the lens of gender bias. What are y'all's thoughts as far as cultural biases in terms of diagnosis, particularly for diagnosing borderline personality disorder in men? Nadine, we can start with you. I imagine you have some thoughts on this one.
Well, I guess the same applies. I mean, having been involved in international conferences, again, behaviors are anchored in culture and socialization and what is sanctioned and not sanctioned for which gender. So culture absolutely has an influence. And how do we tolerate expression of anger or not, emotions in general or not, for example. So that's how I would, for sure, it does influence.
Absolutely. And yeah. Francis, I imagine you see this a lot in your work, as we know that our military servicemen and servicewomen are increasingly becoming a more diverse, racially and ethnically diverse group. I imagine this is coming up a bit more in your work at the VA.
Yeah, so one of the things that's interesting about that, and at least in terms of how I interact with folks in the DBT skills group, we actually don't have, so BPD is not a requirement to participate in our skills groups themselves. So we care more about functional impairment and overall dysregulation, which can have some overlap with BPD and doesn't necessarily. So I do think that BPD can be really challenging to diagnose, especially when working with male veterans who, there's just not as much research done with BPD among men, and thinking about how it can be presented. And then also thinking about veterans and thinking about the veterans that we're working with in the context of the training that they've received. So many of them have been in contexts where the expression of certain emotions is not really viewed as okay. And I think the other thing that I would think about in terms of culture and how culture can impact BPD diagnosis is thinking about the interaction between the provider and the patient as well, and thinking about how depending on how the client is presenting and their own identity constructs, that might influence how the provider interprets the behavior that they're seeing and color whether or not a diagnosis is applied.
Yeah, absolutely. Well, thank you all for your fantastic presentations, for joining us today, and for answering some of the audience's questions. Really, really appreciate it.
Thank you.
Thank you.
Thanks, Emily, and all of our wonderful speakers. We're going to take a brief break. Feel free to use this time to stretch your legs a bit. Also consider which of our wonderful breakout sessions you might want to attend this afternoon. You can find summaries of each of the workshops being offered under the slides and handouts tab below. And we're going to return at 12:20 to hear from our next speaker, Dr. Nathan Kimbrell.
Borderline personality disorder is a problem of pervasive instability in many areas of functioning, which include managing emotions, controlling one's behaviors, relating to others, and building a sense of self. So as you can see, it's a problem that has to do with all our areas of personality functioning. People with borderline personality disorder tend to have mood swings that are reactive to stress. And these mood swings will vacillate between depression, anxiety, anger, and sometimes feeling really quite nothing at all. The other problem of emotions that people with borderline personality disorder may have is that they can get very angry to a point of being enraged. And this leads to inappropriate outbursts of anger and aggression that can become very problematic for relationships. For a long time, we thought that BPD was an environmentally caused disorder, meaning that relationships in a person's early childhood really shaped the likelihood that someone would develop BPD. Lately, research has shown us that more of the disorder comes from genetics, that there is about half of the risk of BPD that is derived from having a biological basis. Most people with borderline personality disorder will have also a mood disorder, mostly depression, or other anxiety disorders, including PTSD in some cases. In addition, people with BPD will commonly struggle with substance use problems, eating disorders, and problems with ADHD. Many of the symptoms of borderline personality disorder become most obvious around the age of transition from adolescence to adulthood, around the age of 18, and it peaks in the 20s and declines in subsequent decades. We believe that earlier detection and diagnosis, as well as intervention, can really change the course of patients' lives.